All right. Well, I am here with Sharon Harris. Now, Sharon has been with us at RPG as an interviewer since I think, gosh, late 90s, 27, 28 years, something like that, Sharon.
97.
Yeah, gosh. And you worked with us on probably the first Mid-America transplant study we ever did, our first OPO study ever.
I did. I remember.
So yeah. So I'm so glad to have you on. And I know one of the things that I wanted to really highlight is you've done a lot of our physician interviewing, you've done a lot of our donor family interviewing, you've done a lot of our healthcare interviewing, talking with hospitals and healthcare systems about referral optimization and patient experience, things like that. So you know this world well, everything that we talk about here, and we have all these family services folks here who are working in the hospitals and dealing not just with the donor families, but of course with the doctors and the nurses and everybody too when they're going in for authorization. So I thought it'd be great for us to just have a conversation and you could share some of your knowledge and experience from all of these interviews you've done over the years. So,
Thank you for having me.
well, thank you. And I'll also mention, and I like to play this up, that Sharon is also a documentary filmmaker, which I think is so cool. And Sharon, can you just briefly tell me a little bit about your documentary filmmaking career?
Well, we made two documentaries. The first was it was called The Stem Cell Divide. It was when the stem cell issue was a big deal in Missouri, all the legislation, but it's a very even-handed picture of the whole situation that was going on at the time and the repercussions of it. The one we made recently is Mr. Z, what happens early in childhood lasts a lifetime. Completely different, different type of thing, but it's all about, early child education and really understanding the impact of addressing emotions in early child care, teachers and students, rather than just the learning aspects and how that can shape. We followed one administrator who was doing just an incredible job, Mr. Z, and it was fascinating.
That's fantastic. And that's one of the reasons that I've enjoyed working with you so much over the years is because you're somebody who has a background in science and you understand how to talk with people that are very academically minded, and that's doctors a lot of times, right?
Right, I love it. Yeah, all the jargon, but just also like being tuned in the same wavelength to help.
Well, let's jump right in, and I want to begin by talking about donor families for a moment. So, let's talk about when you're making calls to donor families. How hard is it to reach these donor families, and how do you get them to participate in this study? Because we don't pay them an incentive or anything for these studies. They participate out of their own free will. They have to want to relive what they went through. So, how do you get them to participate?
So obviously the first obstacle is being able to reach them. And that gets harder and harder, as more people screen calls. A lot of the numbers I get are no longer, people have moved, have dropped that number. And also a lot of people are, don't speak English. So, they pick up and they don't understand and they hang up. So I get a lot of that. When I can reach people, usually I don't have too much of a problem getting them to participate. If sometimes it's a few times someone has said it's just too hard, but usually I do, once I've gotten a hold of them, they are willing to talk.
And I know a lot of the times when we're doing these surveys, we're actually talking to tissue donor families more often than organ donor families. What's different about tissue donor families when we're talking to them in these interviews?
Yeah, a lot of times they feel they didn't have full information. They didn't really always understand what was going to happen with their loved one. They didn't understand what was, a lot of times because it's, happens at the end when it's in the OR. They weren't exactly sure of timelines. They often felt that, they weren't kept in the loop. And then also afterwards, they wanted to know whatever happened with their loved ones' tissues and would have wanted more information.
And I know donor families can be really sensitive too about the time of year when you call, and Like we have dates that we will not call on. We won't call around Thanksgiving. We won't call around Christmas or New Year's. When have you noticed that they tend to be the most sensitive towards the calendar?
So this is a big one because often it seems like the people on my list, it's right, it's right coming up to their first death anniversary, possibly second year anniversary of death. Also, I'm sure, other things that affect them, like they say, oh, it was going to be, my son's birthday or something like that. But particularly, it's a very emotional time if I get someone who, that anniversary of death is coming up.
And of course, we've had many situations where we've had interviews get lost because the person just they're in their grief, they can't talk on that day, or where maybe there's a date we didn't know about, like it's their child, like living child's birthday, or it's a day that they would have done something special together, or there's all kinds of other things that can come up too and interrupt those interviews. And I know part of your job is you have to be really empathetic. you know, you can't just make these calls and try to bully people into participating in an interview. You have to listen to them and hear them out and let them speak. So how do you feel when you're doing these interviews? Tell me a little bit about the emotion of it.
Without a doubt, these are the hardest interviews that I do. And it's because they're so emotional for me, but, empathetically, from feeling what they're feeling. They almost always cry, tear up, get emotional, have to stop during the interview. And what I always do, what I try to always do is just give them their time, give them time to just, gather themselves, talk about it. I mean, I've heard every kind of story imaginable, some of them so difficult. Somebody who was watching their child get hit by a car and what happened, in detail. And they're, reliving these experiences when they talk. So I just, let them talk as much as they need to talk. The main thing is just listening with heart. I mean, that's it. I just listen and I try to let them talk it out. And then they need space, they need to stop. I just, I'm calm and soothing voice. I definitely have a much more soothing voice for these interviews than I do for, the physician interviews, which is a different type of thing. And then afterwards, of course, I'm crying. I need a little bit of, downtime afterwards because it's definitely, it's very emotional. I try to bring, grief that, I've gone through. And when I'm listening to them, to be more understanding and to kind of be, the most sensitive and caring if they're speaking. And they seem to respond to that well and then go on to give me even more and better information.
And what you just said there is so key, that because we are, showing that level of empathy and you're so good at it, that they trust you enough to want to talk to you and to share their experience. And that's really key in these kind of interviews, because we're RPG, we're not an OPO. They don't know who we are, and we're just a voice on the other end of the phone most of the time. And I think I commend you and all of our interview team for just being able to do these, because I know personally I just read the data and I start crying sometimes. And doing the interviews themselves can be really challenging that way. So, well, let's talk a little bit about um, the donor families and some of the the feelings that they've expressed. So, just in general, what kind of feelings do they express about the experience that they've been through when they're going through this donation process?
So what I hear most is, that they're in obviously a shock state, some more than others, and that what information goes in the beginning doesn't always stay with them. They really appreciate, the information and direction they get at the beginning. They're always saying how the OPO has been very kind and helpful and patient with them. But the thing is that then they say it's very difficult, later on to remember things. They'd like to maybe be, updated more about, what happened, to have it gone over again later. They also sometimes feel, a lot of times I've heard where they don't feel that maybe they're being kept up through the process to know exactly what's going on. And, that causes them to feel kind of, in limbo.
And I know they definitely talk about some of the things they appreciate. Obviously, the aftercare stuff that they get, the mementos and things like that, those are a big deal to them. But can you think of anything they appreciate about like the beginning stages of the process when they're in the hospitals?
Yeah, I mean, really the patience of the person that they're with to slow down, give them whatever information in the kindness and the patience really above anything else. I, you know, and of course, as I say, as it goes through updates.
Yeah, and a lot of times, when I'm just reading the data, I notice that they remember specific details, remember people that they talked to, they remember things that they said to them. So their encounter with OPO a lot of times is very memorable, especially for the organ donor families. What about when things go wrong? What are some of the things that you've heard expressed about that when that in-hospital experience just doesn't work out quite the way that they wanted it to?
Right. So one of the big things is the what is it called? The inter the uh interview. What is that interview?
The DRE, the medical social screening interview.
Screening interview.
Yeah.
That was
Hmm.
it. So
Yeah.
that screening interview, a lot of them have felt it's either inappropriate. There were questions that they felt, were weird to ask them, or there were just too many questions. It was too hard for them to go through that. They thought, many said, is there any way to do that at a separate time, or, not right when they're smack dab in the middle of the trauma of it. That seems to be the hardest for them. And then during would be more, if it doesn't seem like appropriate timing or something like that for them, where maybe they're being there, someone comes to ask and they're just not ready.
Yeah, and when they talk about that readiness, are there any things that you can remember they've said where they've talked about timing being bad or things that have caused that timing not to work out so well for them?
Well, something I'm thinking about is, when they feel if somebody's hovering,
Mm.
somebody's kind of, over present and just making them feel like, they don't have their time with their loved one. They're being pushed.
Yes, and we've definitely heard that many times. Are there any other, so the medical social interview, I know uh, one of the issues we hear too is they'll be asked to do it in the middle of the night, especially the tissue donor families, or they'll be asked to do it when they don't have all the information they need, or maybe they'll be asked if they're the wrong person, like somebody else in the family has all that information, but they're being asked to do it. Um, I'm trying to think of, I know there have been other issues that have come up too. Can you think of any others that have involved the DRE? Oh, the sensitive questions, right?
And some of them, you know, weird questions about diseases and things that about them, it just they
Yeah.
kind of they felt that this was just inappropriate or just not the time to be asking that, and also things that didn't apply to the time it was happening. In other words, this was material that could be gathered after or some other time.
I think we were talking prior to our interview here about how they would really like to be able to fill that information out without having to do it verbally. And I know it's a government form, and there's some reasons why it's administered the way it is, but they're often frustrated by the process itself, aren't they?
Yeah, they that's what I was mentioning, that
Hmm.
they would like it to be done some other way or some other time where it wasn't, right in the middle of a shock time, which also they may not even be able to recall things at that point. They're in such shock. But yeah, that also has been a difficulty for them.
And part of the reason I ask this, Sharon, is because you and I, we've done many surveys together, and you've had to occasionally ask some really bad questions. And I don't mean bad in the terms of like ill-intentioned, but just really badly written, and my fault because I'm the guy that wrote them a lot of the times. But there we find out sometimes that questions just don't work, or lines of questioning don't get what we want. So when you're administering a survey to people with bad questions, questions that might trigger them or upset them or confuse them, or you don't get the kind of response you're hoping for, how do you as an interviewer deal with that? What do you do to make those questions, something they can get through so you can finish the survey?
Right. And right. And sometimes, I mean, a lot of times they'll just say, I don't feel, they'll get upset and say, I don't feel comfortable answering that. And then I'll just, you know, I'll say that's fine, and continue on from there. I'm not going to force them. But sometimes I'll maybe, say it, but kind of reword it the same exact thing, but kind of reword it a little bit so that maybe it's more understandable to them. Sometimes they're just confused, they're not sure exactly what that meant. And since I have more of an understanding of what the question is trying to achieve, I can say it in a way that then they're like, oh, okay. And then they go on to answer it.
I know we had one question on the hospital partners study where it was about, was it optimizing DCD or something like that? It was something that really offended a lot of the doctors. We had to throw the question out because it was not intended to offend them, but it really did. And when you come up against that, that aversion like that, is it hard? Do you feel like you're going to lose the interview, or do you have to keep it on the rails somehow?
Usually those questions are at the end of the interview, the really, really tricky ones like that. So we're pretty much almost done. But to get those still, continue, I just move it over in whatever way they're passing by it, if they're just too upset by it, or, saying, well, maybe that wasn't as clear, so let's go on to something else. Or like I said, kind of a little bit rewording it if it's, the same meaning exactly. And then they're like, oh, okay. And then go on. That's really, the best that I can do. I've never had anyone that just said, hung up on me after that or something like that.
Thank goodness.
And then I come to you, Sean, and say,
Right.
something's got to be done about this question.
And we certainly have had interviews with donor families, and I know you've had some of these where they need something afterwards. They need contact, they need follow up from the OPO. They need something in order to help with their grief. When you're sensing that somebody needs something beyond what the interview provides, like how does that feel? Like what do you do with that?
Oh, I mean, I always make note of it.
Hmm.
And I always say, I will be sure to, make sure that's, comes across, and that you'll be heard. I also, then, go ahead and of course, I write it in a place on the survey where that's going to, where you can pass that information along.
And we always, I know whenever we're working with OPOs, we always try to be very accountable. And if there's a problem that can't wait for the report, we make sure that we get permission to share that information then. And of course, our interviews are almost always confidential and anonymous, so that we can get the right information. But even so, like, we don't want to sit on those really upset, charged situations, right?
I was going to say, and I always let right away. I always get
Hmm.
that right away. I don't wait till, I'm inputting the information or anything. I always make sure that, that can be addressed immediately.
Oh yes, yes, and sometimes you're one of those interviewers that you always said you carry guides around in your purse. So if you're out shopping, you can take an interview when you're out and about.
I
Likewise.
don't, the bathroom, where I go, they're with me. Yeah. Yes.
And I was going to say, likewise, I get calls from you and from the other interview team all the time about when things go awry, and I'll take them where I'm out and about. So, well, let's talk about a little bit about the context of the hospital. So, again, we're talking to folks that are in the family services side of things, but a lot of times they're working in collaboration with their hospital development partner, colleagues, or they're working with their hospital partners who are maybe wanting to be present, or maybe teeing up the donation discussion for them so they can go in and obtain authorization. So when you talk to the physicians, and you've talked to a lot of them, what is their perception of what's happening during that donor family encounter?
The physicians really don't really want more information. They really feel like they're not, that they're kind of a lot of times being discounted in the process. Where these patients are there, and the families are there. They'll call them their family, and they want to know from beginning to end exactly what's happening. They want to know the what and the why. They don't feel that they get enough information about that. They feel they're being kind of kept out of the loop a lot of times, that they're kind of being disregarded, and they want to know more. They want to know what happens before, during, and after. At least, a heads up. They're not looking for a load of information coming in. They don't have that bandwidth, but they're looking for, for updates and what's happening, what's going on with that family and that patient.
And I mean, we talk all the time about how there's different types of physicians that have different types of needs, but generally speaking, their attitude towards the OPO is not a negative one. I mean, they generally are happy that the OPO is involved in the donor family discussion, right?
Correct. They in fact, so what I get, right away when I ask them is they're just so happy that it's not on them to do. Emotionally, that's just, they don't have that, they want to be able to do what they're doing and have the OPO take care of that aspect of it with all the emotions involved. They're always very grateful for that. And they almost always respond that they think that the OPO does a great job with that. That part of it is great. And then what was the other aspect that you were asking me?
Well, I mean, they're generally not. Sometimes they can be very hostile towards the OPOs in person, but they generally are not against the OPO being in their hospital, right? I mean, they have respect for what they're doing.
Right. They absolutely have respect for what they're doing. It's sometimes the way in which they're doing it.
Mm-hmm.
Where their location is in the hospital can be very, can be more of a negative aspect. Whether the OPO is, hovering, is, right there, standing, right by the door and kind of in their way. They say, they're like looking over their shoulder, sometimes literally, they've said, following them, but looking over their shoulder and yet not necessarily really introducing themselves or really giving them enough information so they feel that there's a partnership. They're kind of feeling like two separate entities often, and they're feeling like, that you need to understand my side of it. I need to understand your side of it. We can then, get along and be more effective.
And I mean, increasingly, we've been hearing words hovering, lurking, vultures, yeah, all kinds of words like that kind of what I call like horror movie words, right? Like words that are very negative and in connotation. Do you think that part of this has to do with how protective they are of the donor families?
Well, that's what I was saying. They consider
Mm-hmm.
them family. They'll say, this is a family that we have relationship with. And they're very protective. They're very territorial about these things. They want them, they don't want them hurt in any way. And they feel that since they don't have enough information about the OPO sometimes that, they want to have that kind of overseeing authority where at least they're coming to them. First, the OPO would, check the dynamics for the family, kind of, say, so what are the dynamics for this family? Is there anything I should be looking for, whatever? And they're not getting them. Be able to feel that they at least have that part in care.
And one of the things that I think we talked about too was that sometimes they feel like they're almost like pushed out or locked out of the room, right?
Well, yeah, there's, on the question that we have of how
Mm-hmm.
included do you feel in the, in the talk with the family, and most of them say no. Now that's a mixed bag because a lot of them say, well, I don't want to, but then there's others who really would like to be part of it. I'd say maybe almost 50-50. And then of course there's the ones that even if they don't want to be part of that discussion, they want to be part of what that discussion entails.
Yeah, yeah, and we've kind of identified that there are some partners. I call them the hand holders that want to be there. They want to be in the room where it happens, and they want to be a part of that entire encounter. And it might be a really empathetic pediatrician or a nurse or somebody who just really wants to follow the patient from start to finish. And they really care a lot about the interaction that the OPO has. And if they don't like what the OPO is doing, especially if like in a DCD case, for example, where the OPO is pushing for something and the family doesn't feel comfortable with it, the physicians and the nurses and the APRNs, they can get really offended in a way where they don't necessarily want to bring the OPO in as early as they have been, because they feel like they're going to get in the way of caring for the patient and the family.
Right. Well, that's exactly true. Right. They're that, and the other thing I was going to say is they don't feel a lot of times they're getting follow up. So, after the case is over, even they're like, I don't know what happened I don't know what really ended up happening at the end. The OPO person might leave. They're not even often told that that's going to happen. There's nobody they don't often get contact information.
Yeah.
So they're told, that they don't know what happens afterwards. They're kind of saying, well, I wish I knew. I'd like to know. Sometimes they say it more, like, well, it doesn't matter. But you can tell it does matter to them. They really, they really do want that.
And when OPOs have brought the families back on the floor, like they remember that sometimes, and they talk about that in the survey, right?
You're saying when they
When they bring them back like later on, I know we've heard about it in some of the studies we've done where they'll bring a family back after a case and they get to see the family again, see how well they're doing. They like that. That's been a positive experience for them.
Any kind of follow up that gives them an idea what happened with this family, what happened with the patient. I mean that, that with the donor, that's what they want to know.
Well,
always mention they love the letter. Anyone that gets the letter, that's always like a real highlight.
Like the letter from the recipient.
The letter from the recipient.
Yeah.
Well, telling where the letter where the organs go.
Oh yeah, true. When they hear from the OPO about how the outcome of the case was.
Sure, they need the recipient, of course. Doesn't always happen, but when they're, if they do get that letter afterwards, it's a very, it's not a specific letter, but at least it's, saying, kind of a letter thanking and giving them some information about what happened. And that seems to really close, help to close, but not everybody's getting that. And, that you could see there's a thirst for that information.
I would say that's the number one reason that they want the OPO to contact them after the study. In fact, is they didn't get that letter, or they didn't hear back from that recipient, and they want to.
And I'll say something with the physicians that by the end, sometimes it's really hard to get a hold of them because they're physicians, but I've almost every time they thank me. And they are so happy that, they were able to do something like this and to be able to share, to be able to, try to help, to be able to try to get some sort of that, that relationship improved.
Very true. Very true. And again, you do a great job. So I'm glad they are thanking you. Well, one last question for you. Based on everything we've talked about, what are some recommendations you'd have for OPOs to ensure that donor families and the hospital clinical staff are having the best possible experience during that requesting and authorization process?
Yeah. I wrote something down, I wanted to kind of, mention was important. Just a few things that the donor families, especially the tissue donors, I'll reiterate that they just need much more clarity on what the process all throughout will entail at their level. And that's the other thing, people are coming from different backgrounds and different cultural backgrounds and different emotional situations. And they want to, to address them where they're at, make sure that they get the, get some sort of a, feedback, but in real time type of thing going on. That's just the most important. I think that's the most important takeaway. Updates in real time. Also, for like especially the tissue cases, they want to know the outcomes. They want to know kind of what happened with the recipients. Anything that they can get anything that they can find out, really, really important. Again, you know, it just closes that loop and gives them some sort of comfort, as much as they could know, and as much as they're allowed to know. And the other thing I was going to say, kind of in the same vein, is that the OPO reps, I was going to say, kind of being real attuned to each family, knowing that they're so different, because you know they since they don't know, it creates a lot of uncertainty and fear, and I think that's what happens. And if they, you know, leave there feeling that they really didn't, they don't know what exactly happened, that it's very confusing to them, and that's what I've heard from some afterwards. We mentioned about the hovering, and there were a lot of suggestions about that. You know, to maybe find a special space in the hospital, where, like, a room or something that's not right there, where they, and to make sure that anybody who needs them knows. This was especially true with the physicians, but and the nurses, but to know where they are, where they can be, you know, where they can be located. And I think that you know, that would help a lot too. Make themselves known. You know, everybody people want that connection at a time like that, whether, and even the doctors. It's a very emotionally charged time, and they need that connection. You know, that type of you know, knowing who they're talking to, who they're dealing with, and feeling that at least some sort of a bond at that time. For trust.
Well,
For trust.
oh, absolutely. Absolutely. Well, Sharon, thank you so much for sharing your thoughts and perspectives with our best practices community here. We're so glad to have you on, and keep doing a great job on all those interviews you do. I know you're working on OPO studies right now, in fact.
I'm working on a donor family study, absolutely. And yeah, and thank you, Sean, for letting me be part of this. Thank you to everybody for what you do. Incredible work. I'm in awe of what you know, all the OPO people do. It's just it's beautiful.
Me too.
And,
Me too.
Yeah. And thank you for letting me be part of this and share what I know.
All right. Man.